Okay, so hi everyone. The aim of today's session is to provide an outline of the Professional and Linguistics Assessments Board, also known as the PLAB exams. Can everyone hear me okay? You can just put a message in the chat. Okay, great. Everyone can hear. Sorry. So today we'll just be going through a bit about the PLAB exams, what's expected of you, study tips, and importantly, a few scenarios and approaches to some of these scenarios. Importantly, we will also be running a second session in the future, which will be a bit more interactive and mainly based on PLAB 2 case scenarios. And only those who provide feedback via the link, which will be on the last slide, or this QR code alongside the screen, which actually works. Only those who provide feedback will have access to the second session. So please bear that in mind. We need feedback to improve on our sessions, and yeah. We'll also be providing attendance certificates for those of you who provide feedback via the link. In terms of questions, I welcome questions at any time. You can put them in the chat and we can look at them at the end of the session, or if you think of questions after the session, you can email us. Our email address is on the last slide. Okay, so a little bit about me. I'm no expert on the PLAB exam. I am an international medical graduate from South Africa. I graduated in 2016, and then I worked in South Africa for 3 years as a medical doctor before moving over to the UK. I moved over in January this year. I sat PLAB 1 in November 2018 during my internship, and then I sat PLAB 2 in June 2019 while working a full-time job. So actually, while I prepared for PLAB 1 and PLAB 2, I was working a full-time job with a full-time rota, which was 5 days a week of just normal working hours, as well as 1 to 2 on calls a week. And I passed both exams, luckily on my first attempt, and I didn't actually attend any courses for PLAB 2. Then after passing PLAB 2, I applied for jobs in the NHS via jobs.nhs.co.uk. And then that was around September 2019. And then I attended some virtual interviews via Skype and Zoom, which was around end of October to beginning of November in 2019. I then received and accepted offers at the end of October 2019 and started the process of moving to the UK. And then finally, I started my job in the emergency department of a London hospital in January 2020. Since then, I recently changed jobs to a clinical research post just to get more experience in the research field for future applications.
What are you eating?
Okay, sorry, can everyone put their mics off? Especially the person who's eating something. Okay. So just in terms of the contents, today we'll run through an introduction to the PLAB exams, how to apply for the PLAB exams, recent COVID-19 changes to the exams, how to succeed at the exams in terms of what to study, what approaches I used, common errors to avoid, as well as the marking guideline. Myths, we'll discuss 2 myths involved with the PLAB exams, and then we'll run through a few scenarios. Which I'll also ask which will be quite interactive, and I'll ask that you all get involved. Okay, so we'll move on to the introduction. So what is the PLAB exam? It, as I mentioned before, it's a 2-part exam. Part 1 is MCQ based and part 2 is OSCE based, and OSCE stands for Objective Structured Clinical Exam. So part 2 is mainly clinical, and part 1 is based on knowledge and clinical application. So basically, the PLAB exam assesses the knowledge and clinical skills of candidates. Sorry, can you please all turn your mics off? Thank you. Okay, so it assesses the knowledge and clinical skills of candidates to ensure that the candidates are at the level that is equivalent to that of a UK doctor about to start the second year of the UK equivalent foundation program, or UK equivalent internship program called the foundation program. And in terms of who needs to write the PLAB exams or do the PLAB exams, it's generally international medical graduates who have graduated outside the European Economic Area, which is what EEA stands for, or Switzerland. And you generally undertake these exams if you want to practice medicine in the UK. They are alternative routes, but for today, we'll just be discussing the PLAB route. Okay, so in terms of how you sign up for the PLAB exams, it's quite an easy process. You need to go to www.gmcuk.org, and then you need to create a GMC account. They'll be asking for basic details. You'll then need to upload evidence of your primary medical qualification, then provide evidence of English language competency, which can be in the form of a letter from your university, which is what I did, as I undertook PLAB within 2 years of qualifying from my medical school. And most of my courses were, well, all of my courses were taught in English, and this was sufficient evidence for the GMC. So I didn't have to do the IELTS or the OET exams. So if you want to go this route with getting a certificate from your university, you need to be within 2 years of qualifying from the university. And also all your courses need to be have been taught in English. So just in terms of the alternate exams, the English exams, so the IELTS stands for the International English Language Testing System, or the OET, which is an occupational English test. I think for the IELTS, you need a score of 7 in each of the components and overall a score of 7.5. I'm not so sure about the OET exam. And then next, you need to, on the site, you'll look for available PLAB 1 dates and then book for your exam. Generally, there are multiple centers throughout the world. There's just a few problems with certain centers at the moment in view of coronavirus. And you need to have passed PLAB. Well, you must pass PLAB 1 within 2 years of the date on which you passed. Does that make sense? So within 2 years, 2 years after you've passed PLAB 1, you need to have passed PLAB 2. Otherwise, you'll have to repeat the entire process. So just after you pass PLAB 1, I'd suggest you book for PLAB 2 as soon as possible. So even if you do fail or other things come up, that you have sufficient time. Okay, so just in terms of the differences between PLAB 1 and PLAB 2, PLAB 1 is, like I've said before, it's more theoretical, but it also involves a lot of clinical application. It is in the format of a multiple choice exam. It has 180 questions, which are single best answer based. And in terms of PLAB 2, it's more practical. It's an OSCE based exam with 18 stations normally. This is before COVID. 2 of which were rest stations, and each station is about 8 minutes long. In terms of locations, PLAB 1 has multiple test centers worldwide. However, PLAB 2 needs to be taken in Manchester at the GMC. The duration of each exam, they're around 3 hours each. And then in terms of question banks for PLAB 1, I used Past Medicine. I found it very useful because it not only provides questions, but it also has the related up-to-date guidelines linked below. There's also Pass Test. I haven't used it before, but I've heard it is quite good. And then in terms of PLAB 2, there are courses available, but again, these are expensive and also they require a lot of time. And if you are working a job, a full-time job, you might not have the time for this. In terms of preparation, So for me, I booked for PLAB Part 1 in June 2018, and then I sat the exam in, like I said, November. I think I started preparation in about August. So that was about 3 or 4 months. But as I said, I had a full-time job at the time. From friends, I've heard that friends who are unemployed, they studied for PLAB within a month, PLAB 1 and PLAB 2, and they also passed. So just in terms of COVID, changes to PLAB 2 in view of COVID. So pre-COVID, there were 16 stations with 2 rest stations. Currently, they're running 12 stations with 3 rest stations. They are also, the stations are still the same length of time. They're 90 seconds long. And the total examination time has just been slightly reduced. The location is still the same, GMC in Manchester. Okay, so moving on, in terms of how to succeed at PLAB, we'll go through what to study, my approach, some common errors, and a few myths. So in terms of what to study, I found that it was really useful on the GMC website. There's something called the PLAB blueprint. It can come in the form of an Excel document or Word document. I prefer the Excel document. It has a list of, it's very comprehensive, of all the procedures and medical topics which may be tested. So an example is here on the right-hand side of the screen. This is an example of practical procedures that are expected of you and what competencies you need and safety issues around that. You just need to remember that everything you'll be asked will be at the equivalent of a foundation year doctor. So it's nothing too stressful. And having graduated from medical school, you should have most of the knowledge. It's just, refining your clinical skills. I think that's the main part of it. Other sources of information about what to study is you could have a look at what the UK foundation program, the first year, so if foundation year 1, you can have a look at what that looks like. You could just have a look at that on the internet. And then the GMC also provides their own guidance and certain topics on good medical practice, and there are a few interactive tools which I watched all the GMC videos before my exams, and I read the guidance. In terms of courses, I can't talk about them much because I haven't attended one, but from what friends have said, they generally, some found them useful, some didn't, and some still failed. So it's really up to you whether or not you attend a course. It's just something to bear in mind that the courses are not validated by the GMC. The GMC is not monitoring them, and they are not a requirement to pass. This is a bit more about the blueprint. So here on the left, we have just some competencies regarding health promotion, patient education, and public health. And then on the right, we have, teaching and training and competencies regarding that. Okay, so moving on, in terms of what I studied, I read the Oxford Handbook of, well, let me not say I read the entire Oxford Handbook of Clinical Medicine, but I went through the medical emergencies and certain topics, but I went through it with the blueprint in mind. So I'd go through the blueprint and then read a certain topic. And then I also found the Oxford Handbook of Clinical Specialities quite helpful for topics like gynecology, and I think a bit of ophthalmology is in there. I also found that quite helpful. So I suggest you invest in those 2 books. And then, as I said, I read through the GMC guide on good medical practice. I watched all the GMC videos. I also went through the topics from the blueprints, and I read up on motivational interviewing or counseling, breaking bad news, and ethical principles. I also, I practiced a lot. I practiced with friends, colleagues from work, and also other PLABers. My practice with other PLABers was basically mostly virtual because I basically landed in the UK for my exam, and 2 days later I did PLAB 2 because I wanted a holiday afterwards and I didn't really want a long lag time before the exam. And then basically what I found really useful is whatever I studied the night before or went through, I tried to integrate it into my daily practice as I was working during that time. And I think this really helped to consolidate everything I learned. Other resources that I found useful and which are also completely free are OSCE Stop and Geeky Medics. Okay, so my approach, I think, on the exam day would be not to be intimidated by others. I mean, I met a few people, and before the exam, they were all asking about which course I attended and how did I find the courses. And then I told them I hadn't attended one, and then they said to me, "Oh, you're going to fail." So that wasn't actually, I think in hindsight, I shouldn't have spoken to anyone before the exam because that was a little bit stressful. Don't speak to anyone, and I think you should be fine. And don't be stressed if you don't have the time or the money to attend a course because it's really not essential. Something that's really important is when you have a few seconds before you enter the station, you should read the scenario and try and read the scenario more than once and pick up any keywords. So keywords like in the scenario, you should assess the patient, or just look for the key functional word of what you're required in the station. And also just pick up, the important patient information in the scenario. Also, I think something that's really important is to be observant, look for clues in the station. So for example, there might be the BNF, the BNF, which is the British National Formulary, which is basically like a list of all the drugs, indications, contraindications, things like that. So if that's in the station, you'll be able to use it. So anything you see, you are able to use, and those can also be clues as to where the scenario is going. For example, if you see a patient with a neck collar on, think of neck injury or whiplash, or if you see a patient with a pregnant belly, just keep that all in mind. Something that's also really important is to listen to the patient. Don't interrupt the patient. And when you listen, actively listen. So actively listening is actually a skill. It's the skill of listening to someone and then reflecting on what they've said. And also acknowledging what they've said, acknowledging feelings. Avoid any medical jargon. I know it can be difficult, but just try and use simple language which patients can understand. I think something that's really important, which I picked up when I practiced with other PLABers virtually, is the use of rehearsed phrases, which make you really sound like a robot. So try and avoid rehearsing stock phrases as much as possible, and just let the consultation flow, be logical and organized, and try not to stress. Just take it as a normal day at work or in a clinic setting. So common mistakes to avoid, according to the GMC website, is to avoid, the stock phrases I was talking about, such as, "May I ask you a personal question?" "Everything you say will remain confidential." Now, with this phrase, the confidentiality one, I think there are certain stations where, or certain scenarios when you have a patient with you and where, it is useful. So for example, if you are suspecting that there's intimate partner violence or something like that, you can reassure confidentiality. But I don't think it's necessary in every single station to say, everything we say will be kept between us, because that's basically something that we shouldn't have to say as doctors. It's just something that the patient and ourselves should both have an understanding of. And then another question is, "May I ask you some questions?" The patient has come to you for a reason. I don't think you need to ask them whether you can ask questions. I think if it's something more personal and private, then you can say something like, "Is it all right if I asked about your menstrual history if you're a male?" Or, "Is it all right if I asked about your sexual history?" Something like that. But otherwise, I don't think you should ask that question. And also, please don't refer the patient to the internet. They've come to you for a reason. They don't want to be referred to the internet. So in terms of PLAB 2 myths, the first one is, you need a course to pass. This is false. Courses might be good, and I have nothing against courses at all. And just from what I've heard from friends and colleagues is that they're time consuming, expensive, and they don't guarantee that you pass. I've read lots of stories on Facebook where people are really angry because they've attended courses 1 or even 2 times and they still have passed. I think it's because examiners can pick up when you've attended a course and you just sound like you've just rehearsed everything and you're just spitting it all back. And then I think that's probably a reason why some people fail even after attending courses, and more than one course also. Another myth is that PLAB 2 is difficult. It's really not difficult. If you put in the time, revise, and practice, it will be completely fine. Like I said before, the knowledge that is required is at the level of a foundation year 1 doctor. And the GMC just wants to ensure that you're a safe doctor. It's basically all they want to know. So the next section, which I'm sure most people are more interested in, we'll move on to the scenarios, the marking guideline, and then a few practical examples. So I basically made up these scenarios. They're not based on my exams or based on previous scenarios. They're just things that I think are important and that I've made up. Okay, so in terms of PLAB 1 tips, I found it really useful, the sample questions on the GMC site. So like I've said before, read through the Oxford Handbook of Clinical Medicine and Clinical Specialities, visit the GMC site for sample questions, and then you can also search for question banks. There are quite a few out there. Like I said, I used Past Medicine and I found that it really worked, and I didn't find the exam challenging at all. So this is a sample question from the GMC site. I'm just going to ask that if you guys can read through the scenario, and then if you can put down your answer in the chat of what you think the answer should be. Okay, good. So far I've gotten received 2 responses. Anyone else? Yes, so everyone who has responded is correct. The answer is paracetamol. Yes, E is correct. So well done to those who answered. But this is basically the type of question you would get asked. And yeah, just admitting a few more people. Okay. So from the GMC site, I also found this scenario, which is an example for PLAB 2. So the scenario is you are in a mock consultation with a patient played by a role player who has been briefed about their condition. You are foundation year 2 doctor in the rheumatology unit. You are told that your patient, James Horton, age 45, has been referred by his GP with pain in his right big toe. You are not given any other information. You must assess and manage the patient. You'll be given 8 minutes to complete the scenario. So this is what I meant by reading the scenario. So what I did is I read through the scenario twice. I think the key words here, well, the key points here would be to remember the patient's name. If you can't, that's okay. Just remember what unit you're in. So rheumatology, that will give you a clue to the diagnosis. And then just remember the presenting complaint. So pain in right big toe. And the keywords here I would say are assess and manage. So they want you to take a history, offer to examine. The examiner might tell you that's not needed. And then finally come up with a management plan, which is patient-centered. So do any of you want to try and tell me what you think? is going
Yes,
on here, what types of questions you would ask.
yeah. We'll start with the patient introduction. So greetings and introduction of the patient.
Okay,
After that, once we'll confirm, I mean, do you want me to perform or do you want me to just give you the brief idea?
it's up to you. It's up to you if what you'd like to share with everyone.
Okay. So basically, you'll greet the patient. You'll try to develop the rapport with the patient initially after confirmation of the name and age of the patient. You'll ask him for the presenting complaint, in which the patient is going to tell you about the pain in the right big toe. Now, once any factor of pain is there, then in that case, you have to elaborate the complaint of pain in detail. So you'll ask for the onset, you'll ask for the duration, you'll ask for since how long, how is the type of the pain, the character of the pain, what is increasing that pain, which factor is decreasing the pain. So everything you're going to ask one after other, and is there any radiation of the pain? Now, once you finish with the pain history, then you're going to ask the patient about anything else. So is there any other complaint which patient is going to give you? So that anything else may give us the point towards the diagnosis, or it may lead you to differ from the other differential diagnosis. So if the patient is giving you the complaint, that yes, apart from that, doctor, I'm also having, maybe he will say something like swelling of the legs or something, some additional complaint he may give you. If that is the case, then you may elaborate the second complaint. Now, after that, you need to rule out the DDs of the joint pain. So, which are the factors which can cause the DDs of right toe? Once you take the history in detail, then you'll go with the past history. In past history, you will rule out all the medical illness. So, hypertension, the diabetes, and any past medical illness, any surgical illness. In that, we may come to know that the patient is basically taking high blood pressure medicine. That may be one of the possibility. And the patient is on high blood pressure medicine. There is a highly chance that the patient is on diuretic. And one of the side effect which we know that the patient, if it is on diuretic, it can cause sometimes the condition called gout. So, once you take the complete history in detail, then you will go to the lifestyle history of the patient. In that, we may like to see whether the patient is having any alcohol or smoking or anything. And after understanding that, then we will examine the patient, we'll check the vitals, we'll check for the systemic examination, and then we'll reveal the diagnosis to the patient that this is the particular diagnosis which I'm suspecting. Now, then comes the management of that. So you'll explain the management in detail. So you may have to tell that, okay, this particular drug may be the culprit medication for this particular pain, and I may have to remove this particular thing, and I may have to substitute with some other medications. And then you will explain the safety netting to the patient. So if in case the such kind of pain becomes worsen, or if you feel the numbness of the toe, or if you feel some kind of safety netting you have to add, and then you have to explain the follow-up visit for the patient.
Okay, I think that was very well done. I don't know if anyone else wants to provide any feedback.
In the throughout the station, actually, it's very important for us to maintain the interpersonal skill with the patient. So
Yep.
more than history taking, more than data gathering and explaining the management, I would say we should pay attention more to what patient is talking with us. So if patient is showing some concern, we need to show sympathy and empathy at that particular moment. You should not miss that opportunity. Whenever the patient is giving you the opportunity, just look at the feelings and emotions of the patient. So if patient is having some fear, you need to immediately, there and there give support to the patient. If patient is showing something like some kind of, that she is very unhappy or sad, then we need to, show that, yes, I can see that you are sad, or you're not uncomfortable, or
Yep.
you're not comfortable. So in your interpersonal skills are throughout they are going to be tested. So
Yeah, okay, thank you for that. I think that's very good. So say for example, I said, Doctor, I'm feeling really sad, my big toe is really affecting my work. How would you show your interpersonal skills? Can anyone give me an example of how they would try and demonstrate to the examiner their interpersonal skills? Okay, so for that example of someone saying that they're feeling sad and it's affecting their work life, I think it's important to start with acknowledging it. So say, I can hear that you're really upset, and I can understand how a painful big toe can result in you not being able to continue with your daily life activities. And I think just by saying something like that, you're already acknowledging that you've listened, you've shown active listening actually. You've also reflected on what they've said, and it just shows the patient and examiner that you're listening, and you're actually thinking about what they've said. You're not just listening, but you're listening actively. So throughout the consultation, I advise that you just use little things like that when you hear that the patient is feeling any emotion, or yeah. So just in terms of what the GMC site said for what they were looking for in terms of the scenario. So what they wanted for you to pass is to find a history of acute recurrent monoarthritis, which responds to NSAIDs, find a medical history of any medication, psoriasis or trauma, find out appropriate lifestyle history, make a diagnosis of possible gout, recommend appropriate management, and then importantly, where you will get your marks on interpersonal skills is identify patient concerns, listen appropriately, display empathy, and then finally conduct the consultation fluently and professionally, which I think that Maya did do quite well. So in terms of PLAB 2, the marking scheme, there are 3 domains, and you can get a maximum of 4 marks for each of the domains. There's the data gathering, technical and assessment skills, which is just looking at your ability to take a history and ask the appropriate questions. So for example, if you have a station of someone with a female presenting with a painful big toe, for example, if you're going to ask about the menstrual history, I think this is going to detract from your history taking skills, because your questions really need to be focused and you're not going to have enough time to finish the station actually. The next domain is clinical management skills. And my interpretation of this is they're going to look at your management plan and whether your management plan is holistic. Does it involve the patient? Or are you just telling the patient what you would like to do in terms of management? You also need to make sure that the patient is happy with whatever you're suggesting, because some patients don't like taking a lot of medication. So you need to ask them along the way, would this type of drug suit you? Or, you know, would you like to try non-drug therapy first and then move on to drug therapy? And also just explain everything to the patient along the way. And I think you'll score the marks for the section. Some stations themselves might ask you to demonstrate clinical skills as well, which I think forms part of this section. In terms of interpersonal skills, so like I've said before, active listening, ensuring the patient has a good understanding, developing a good rapport, and eliciting and addressing patient concerns. A good way to do this is something called, I call it FICE. So asking the patient if they have any fears or ideas as to what has caused, for example, painful big toe. Then looking at what concerns they have, which is where they might mention that they're concerned about work. And then the E stands for expectations. So that's FICE, fears, ideas, concerns, and expectations. Okay, so we're moving on to another PLAB scenario. So you're an F2 doctor in the acute medical unit. An angry relative, Mrs. Water, is waiting outside the ward and would like to talk to a doctor as soon as possible, as they have heard that there was a delay in administering their mother's medication. So their mother is Mrs. House. And you're currently the only doctor available in the ward. Please talk to Mrs. House's angry relative, address her concerns, and come up with a management plan. Does anyone want to try someone different, try and suggest what they would do? You can even put down some suggestions in the chat if you don't want to unmute yourself.
So, Natalie, if it is possible, if anyone can take the role of the Mrs. House angry relative, then
Yeah, I was thinking the same. Like, if you can just do it in a like real life scenario.
yeah, I can try that. I can try that.
You can try that. That I
Okay,
can
I
be the
don't mind.
doctor.
I don't mind being Mrs. House, and then someone can be the doctor.
Yeah, I can. I,
Can-
I can try for doctor. I don't mind.
Okay, so don't mean Mrs. House. I'm Mrs. Water. If you see what I was getting at here, Waterhouse. Okay, I'm Mrs. House. So if you want to start,
Yeah. So basically, I have to speak to Mrs. Water. She's the relative, right?
yeah. So, I mean, I'm Mrs. Water. Yeah,
Yeah. Yeah. You're right.
yeah,
Yeah.
yeah.
Okay.
Okay.
So, hi, I'm an FI2 working in acute medical unit. I'm Dr. Maya. Can I please confirm your age? Sorry, can I please confirm your name?
Hi, I'm Mrs. Water.
Yeah,
My
Mrs. Water. It is pleasure meeting you. And I suppose you are a daughter of Mrs. House. Am I right?
yes, Mrs. House is my mother.
Yeah, yeah, yeah. Yeah, Mrs. Water. So tell me, how can I help you today?
I'm just really frustrated and upset because my mom has just called me a few minutes ago, and this is actually a recurrent problem. She calls me every day and says that the nurses just aren't giving her medication on time, and when she asks for it, they're quite rude towards her. So I'm really upset by this, and I think I just want to take my mother home because I don't think you guys are doing anything beneficial for her.
Okay, I'm so sorry to hear this, Mrs. Water. I mean, really, I mean, it's really, I would say, apologize from my team for whatever wrong has happened, and I'm really not sure why there is so much of delay in administrating the dose. Let me find it out for you so that I can help you in the best possible way. Well, I must say, Mrs. Water, that your mother is in absolutely safe hands. She is there in the best of the care, and we are going to take complete care for her. You really don't have to worry on that. I really do not know what exactly went wrong that time. So once I'll speak to the nurses, as you rightly pointed out that there was some problem with the nurses and they were not willing to come. So let me just go and find it out, and I will check it out with them what exactly must have happened, where they went wrong, and why there is a delay. So I think it's very important for us to currently go with the management of your mother. So are you understanding me, Mrs. Water?
No, but that's all very good and well that you're going to correct the problem now, but she's already missed all of her antibiotic doses on the previous days. And I think she's just getting worse. So I don't see what the point is of you going to speak to them now. I think it's a little too late.
Well, I'm really extremely, sorry for whatever the situation is happening, and I'm sure such kind of thing will should not happen. Um, I'm pretty sure that she should not have missed the doses on the other days, but there can be some delay in today's dose. So I let me find it out. What I'll do is I'll first find it out about her doses schedule, and at the same time I will like to immediately start her on antibiotic so that she should not be delayed for the further line of treatment. Now, once we commence the treatment for her, Mrs. Water, then I will check it out that what has happened because of which there was a delay. So if you allow me, then probably I can start doing something so that, we can give her the as early as possible the medications. Am I making sense to you?
Yes, that does make sense. Thank you for that. But I would like to take this up further. So what can I do?
Oh, yes, Mrs. Water. I mean, it's totally your right, and I can totally understand your concern. I can see that you are such a lovely daughter and you're taking a lot of care for your mother. So I really, truly appreciate that from my heart. And I'm sure you must be really feeling very, very, very bad on this thing, whatever has happened. And if you feel that, there is something which is really, the medications were not administered properly, or there was, some kind of treatment which has not happened rightly, then definitely definitely, we have a service called as Patient Advisory Liaison Committee. So it is called PALS. This is a system in which you have a right to go and you can complain them, so that they will take it to the highest authority. And the basic aim is so that, such kind of mistake should never happen with any other patient. We will take care, that such kind of things will be reported on nationwide, so that, such kind of thing, any mistakes which has happened because of whatever XYZ reason, should not be affecting the management of the patient elsewhere in across the world. So we work in very effective system, I can say, and we take every complaint with respect and with full potential. So you definitely have a right, and I will give you the numbers, and you can contact them. Does that make sense for you, Mrs. Water?
Yes, it does. Thank you very much. Okay, I think you did really well there. I think we'll end there. I think you acknowledged my feelings really well, and you reflected really well. I also think that you also made me part of it and kept on checking that I understood what was going on. Just in terms of what I had down for what I would have done. So this is my approach to an angry patient or an angry relative. So in terms of a suitable setting, I think just for exam purposes, don't change the layout of the exam. Just let everything be as it is. If you want, you could position the chair slightly differently. At the suggested 45-degree angle to make it more personal. But I think in real life, just make sure you're in a quiet environment. And then in terms of collecting data where you'll be scoring marks as that's one of the main domains, I think just by what you did really well is you showed active listening, you acknowledged feelings, and you also reflected on them. And then you also did apologize on behalf of your team. And I like that you didn't blame anyone. And you did say that you would go and inquire as to what happened. But I think for the exam purposes, don't defend anyone, don't blame anyone, don't make excuses, and don't say that you weren't there at the time, because I think that just reflects poorly, because you're working as a team. Don't try and push blame onto anyone. And then finally provide a solution. So I've gone into this in more detail. So for collect data, just in terms of setting, so ask them to sit down. I think it's better in terms of just dynamics if you're both sitting down, because if one is sitting and one is standing, they're different dynamics of the relationship, and it can be intimidating if the patient or relative is standing and you're sitting. You could offer them water, introduce yourself, confirm their relationship to the patient, as you correctly did. And then in terms of collecting data, go through their concerns, listen actively, acknowledge and reflect. So an example is, I can see this has really frustrated you. Important to make eye contact, use hand gestures, and also give them a chance to speak. Don't interrupt them at all, just let them say everything they need to say. And then in terms of management, so apologize, offer solutions. So like you said, I'll personally speak to the ward staff on duty and let them know of the incident. Also ask them to ensure that every drug chart is checked and that the medication is given in a timely manner. It's also important just to validate what they've said. So for example, if I had said, isn't it important for every patient to get their medication on time? You could say something like, you're correct in saying that it's very important, and it does impact on your mother's management. And I agree with this, just to basically affirm what they're saying and make them feel like they're being listened to. In terms of prevention, I think it's important to also say that you'll discuss this incident with your seniors to come up with further plans to avoid this in the future. You'll also write this report as an incident, as a ward incident. We have something in our hospitals called day ticks, where we put everything down, any incidents that occur, and you'll flag this for discussion at our clinical events meeting. And then, like you correctly said, you can refer them to PALS, and generally there's an office everywhere in the hospital. You could just say, I'll give you the direction to PALS. And then finally, you need to come to an agreement. So like you did really well, ask the patient if this plan sounds good with them, if there's anything else you could help with, and if there's anyone else they would like to speak to. So I think well done. Thank you for that.
Thank you.
Okay, so now we have another scenario. So You are an F2 doctor in the A&E. You are seeing a 24-year-old lady, Mrs. X, who has presented frequently due to recurrent injuries. Today, she's presented with a painful back. Please take a history and offer appropriate management. Does anyone want to try this? If you don't want to try it, I can just run through what I have done. But if you want to offer any suggestions, you can put them in the chat or unmute yourself. Anyone have any thoughts on the scenario? So we have one in the chat. No.
I don't mind trying it.
Okay. Okay, thanks, Natalie. Yes, you're correct. Sounds like domestic violence. Okay, it's good. So everyone's picking up. Sounds like domestic violence. Okay, so what would be your approach? Let's say I am Mrs. X. And I've just come into the side cubicle with you, Maya.
Okay. So do you want me to do it in the same way, or you just want me to?
It's up to you.
Okay, so I'll do in the management way only then.
Okay, yeah.
So hi, I'm Dr. Maya. I'm an FI2 working in A&E. Can I please confirm your name and age, please?
I am Mrs. X. I'm 24 years old.
Yes, Mrs. X, pleasure meeting you. How can I help you today?
So doctor, I think I bumped my back or something, but it's just really sore. Yeah, that's all.
Okay, I'm so sorry to hear that, Mrs. X. Are you comfortable to talk with me?
I guess so.
Okay. I mean, do you need any painkillers, or you are comfortable to talk with me currently?
I think I like something for pain, please.
Okay. Do you have any drug allergy?
No.
Have you taken any painkillers in the last couple of hours?
No, nothing.
Okay. As examiner, I would like to give one painkiller to my patient. Okay. And after giving painkiller, how are you feeling now?
I'm feeling okay, I think.
Okay. So Mrs. X, can I take some couple of history from you so that I can come to the diagnosis and I can help you in better way?
Okay.
Yeah. So would you mind if you can explain your back pain to me in a little bit more detail?
Well, I just tripped the other day, and since then my back has been really sore.
Okay. Is it happening only in the lower area, or it's just the complete back?
I think it's all over my entire back.
All right. Okay. Is there something which is increasing your back pain?
No. What do you mean?
Okay. Anything, any work activity which is increasing your back pain?
I think everything. I just want to just stay in my bed all day.
Okay, I see. I can understand that you must be feeling very bad. That means, okay. Do you have any other complaint apart from this, X?
No, I don't think so.
All right. Is this happening for the first time with you?
Well, I do get back pain for months now.
I see. Okay. So have you taken any kind of treatment or anything to relieve your pain?
Just paracetamol now and then.
Okay. Is it relieving you?
Not really, because then I normally just fall again and then injure my back again. And
okay. Yeah. All right. You mentioned the word fall to me. Would you mind if you can explain how this fall is happening?
Well, I think I'm just really clumsy and I just trip.
Okay. Has this kind of thing happened for the first time with you?
No, it's happened like 2 or 3 times this year.
Okay. All right. What exactly were you doing when you were having this history of fall?
I can't remember.
Okay. All right. Is there anything else which you wanted to mention to me, X?
Mm, sometimes I hurt my arm.
Okay, all right. Fine. I would like to know, are you suffering with any kind of medical or surgical past illness?
Well, no,
Mm-hmm. Any kind of um, chest pain or any kind of fever?
no,
Mm-hmm. Do you have any urinary complaint or any white discharge, vaginal discharge?
no.
Okay. I would like to know something about your personal history. Is that fine with you?
Oh, okay.
What's your marital status?
I have a partner.
Okay. Are you sexually active?
Mm, sometimes.
Okay. Are you using safe contraception?
No, because my partner doesn't like it.
I see. Okay. Do you have any complaints when there is during sexual relationship?
No, but I often bleed.
You often
Often.
bleed. Okay.
Yeah,
You often bleed during the sexual relationship?
often. I thought it was normal. Isn't it normal,
Okay.
doctor?
Not really. So, if I can ask you a little bit in detail, Ax, you can have trust on me and you can open up with me if I'm asking you a couple of questions more. Is that fine with you?
Sorry?
Is it a kind of only simple vaginal intercourse, or are you following even the oral or anal relationship?
No, it's normal.
Okay. Do you have only single partner or do you have multiple partners?
I only have one. Why are you asking me this, doctor?
Yeah, because it is related with your history. So if you are having the bleeding, then
Okay,
I
but
need to
doctor, I
know.
just want my back to be sorted out. I don't know why you're asking me these strange questions.
Okay. Okay, no worries, no worries. If you don't want to answer anytime, you can always say that you're not comfortable and then we'll proceed with a different set of questions. So that's no problem. All right.
Okay.
How is your relationship with your boyfriend?
It's fine, I guess. I mean,
Okay,
sometimes he can be angry and like stuff.
okay. X, you can have complete trust on me and have this thing that, you know, whatever conversation we are having here is absolutely confidential. So if there is any kind of anything where you feel that you need to tell me, you can tell me, there is no problem. Because as I can see with your history, if you're having a multiple history of fall, you know, there are a couple of things which I'm not finding right in your history. Am I making sense to you?
Yes, doctor, it's making sense.
No, see, I can truly understand what you're going through, and please, I'm there to support you all the time. And I will promise you that we will give you all the support services, including social service and everything, where you know who will take care of you in all the aspects. So you can tell me whatever is there. I will take care of you completely. Not to worry at all.
Okay, I think you can pause there just because you're running out of time. But I think it was well
Yeah, that's what
done.
even I. Yeah, I'm so sorry. Actually, I was trying to, but you know, I think
I
the
know, I
time
know.
was.
You see,
Yeah,
the whole point is that these scenarios are very tricky. I will just share now with my approach to it. But I
yeah.
think you did well. But I think there is some stuff we could probably work on. So I think another aspect is that it was probably difficult because, you know, it's not a face-to-face scenario, but in the
Mm.
actual scenario, you would look for non-verbal clues. So maybe if she had like a bandage on her arm, and then like you did, reassure confidentiality, but also just acknowledge her emotions and provide non-judgmental support. And I think just something to bear in mind is I would have developed more rapport before you asked the sexual history. And I think in the situation of where you're leaning towards physical abuse, maybe I wouldn't have asked the sexual history first or so early. Um, but other ways to show support could be making eye contact, being empathic, so saying, I'm sorry you're going through all of this. And then, like you did, mention all the support groups, and then also just mention that it is difficult to talk about the abuse when I did finally come out and say it, and just say something like, you are very brave for sharing this, because it is quite difficult if you had a situation with a patient who has been abused. It's very difficult when they do eventually tell you. But I think in the exam setting, they probably are more likely to, depending on how much rapport you develop with the patient, well, the prepped patient in the exam, I think they will slowly open up, just because there is the whole time factor. And then I think an important question to ask is, who did they come with today? Because I think that's a really important question, because if they're here and the abuser's waiting outside, they might be really afraid and they might not want to say anything to you. And then when asking about the abuse, use open-ended questions. So I think an important question which will break the ice is something that like, can you tell me a bit about how things are going on at home? And then they might say, no, not so good. And then you could ask why, and then go into it that way. And then also important to ask about children. Who is the breadwinner? So do you work, or does your partner work? And then another question, once they do come out with having some a problem with their partner, you could ask, do you ever feel afraid of your partner? And if they say yes, you could say, can you tell me more about why you're afraid of your partner and what happens when you're afraid of your partner? And then also, I think it's important not to just assume that the perpetrator is the partner. So always ask, who is this person that has hurt you? How are they related to you? When did it start? How has it progressed? Do you feel safe to go home today? That's a really important question. And it's really important to risk assess and see whether or not it's safe for this person to go home. In terms of social history, so we've already covered most of it. So employment status, who they live with, have they ever thought of leaving, and why, or why they have or haven't. And another important question is, do you have anyone who is supporting you? So ask about family and friends. And if you were to think about leaving, do you have someone you could trust, who you could stay with? In terms of a proper risk assessment, which I'm sure the examiner is probably looking for, you could ask things like, have you ever been threatened with a weapon? Does this person have a gun? Have your children ever been hurt? And more specifically, questions about the person's mood, so the patient's mood. How are you feeling today? Has this affected your mood? Have you ever considered harming yourself or harming your children? And then, because then in the management plan, once you've discussed management with the patient, you're probably going to need to feed back to the examiner and say, well, I think this patient is quite high risk because of X, Y, and Z. So for example, because she has low socioeconomic status, her partner is the primary breadwinner, there's evidence that there is a deadly weapon involved, there are children involved, and the violence is escalating. And I think that would be a good assessment, just to show the examiner that you've thought of everything holistically. I think you were alluding to this a little bit, but I think an important question would be to ask the patient if they have any psychiatric illnesses or mood disorders, because I think this just makes them higher risk. Whether they use alcohol or drugs, and whether the perpetrator also uses alcohol and drugs, and whether the perpetrator has previous convictions. Yeah, and then throughout, just look at fears, ideas, concerns, and expectations. And then, so in terms of coming up with a plan, I think by providing reassurance and actively listening, you're already halfway there. But like you did, provide sources of support. So there's something called the National Domestic Abuse Helpline. You can tell them if they feel that there's imminent danger, they can call 999. There's also a Women's Aid live chat service. and victim support free 24-hour confidential services, which you could offer. Also, remember that you can't force anything on them. So you need to continuously say, would you like me to help you? Would you like me to refer you to services? Not just here are the numbers, you can call them. Keep on asking them, because this shows that you're collaborating with the patient rather than just telling the patient. And then finally, safety netting. Tell them that you'd like to schedule a follow-up because you want to know, is this woman okay? Yeah, so schedule that. Okay, next scenario is just, it's actually not a scenario. It's just my approach for the sim man station, which I know lots of people worry about. But I actually, this is the approach I actually used. So go through the A, B, C, D, and E. So if you're just an FY1, FY2 doctor, so for the purposes of the exam, and also just in general medical practice, call for help. I think in terms of airway, if the patient is talking, you can just say to the examiner, well, this patient is talking, so I think the airway is clear. Always remember the C-spine, especially if you see something like a neck collar sitting in the station. And then you could say something like, I will assess the C-spine, and say how you would do it. So if they're already in a collar, you can do the a log roll and then feel for point tenderness along the spine. But then the examiner might say to you, C-spine is cleared. But also just keep looking for clues around you. In terms of breathing, say you would count the respiratory rate, they'll probably stop you and just say, that's fine, the respiratory rate is 16. Then you can say, okay, that's normal. So keep feeding back and keep saying what you're thinking, because each thing you say or do actually scores you points. And then say you'd listen to the chest, and then you could say, they'll probably say to you, patient has good air entry bilaterally, patient is under stress. Then just move on to circulation. So say you would like a blood pressure reading, pulse oximetry, and the pulse. And remember to say you want the rate, volume, rhythm, all of it, and do as much as possible, do everything on the mannequin. In terms of capillary refill time, do it on the mannequin. Feel the peripheries. And then moving on to disability, you need to know the GCS scoring system well. I have heard that sometimes, they can provide you with a chart, but I think just knowing it is much easier. Check the pupillary light response and the size, and then E, everything else. Check the glucose, temperature, a head to toe exam, and secondary assessment. Again, do everything. So if you want to feel the calves on the mannequin. If you want to feel the abdomen and do and say what you would do as you're going along it. And then you should be picking up, as you go along, you should be picking up all the abnormalities, and then you need to bear these in mind and keep thinking of what your differentials are, because at the end of it all, they will ask you, okay, what do you think this is, and how would you manage this patient? Okay. Yeah, so I mentioned all of that. So at the end, it's important to give an assessment, because this is, the 4 marks on clinical assessment and all that. You probably get the majority of your marks from this. So the patient is likely to have an acute asthma attack based on their inability to talk, tachypnea, low saturations, reduced air entry bilaterally. Oh, sorry, something I forgot to mention. As you go along, say there's an abnormality. So say, for example, on breathing, I said the patient is tachypneic and the SATs are 88%. If you see a face mask in the station, take it and put it on the mannequin and say, I am putting this patient on face mask oxygen at XY liters, and I'm also giving them, I'm going to nebulize them with salbutamol and ipratropium bromide, and tell them how much, so 2.5 milligrams, and all of that. And then also mention that you give IV hydrocortisone. So as it happens in the station, mention your management, because then this avoids you having to remember everything, and you might forget things at the end. So as it happens, say what you're doing. Okay, so I think this is the last scenario. This is just an example of how to a station and just in general medical practice, how you should give a referral to a colleague. So you're an F2 doctor in the ED, you've clocked a 50-year-old man, 50-year-old patient, known with CCF with a 1-week history of fever, shortness of breath, worsening orthopnea, PND, which is paroxysmal nocturnal dyspnea, cough productive of green phlegm, and ankle swelling. On clinical examination, the patient is pyrexial, normotensive with a respiratory rate of 28, SATs of 90 on room air, reduced air entry over left lower zone, bilateral pitting ankle edema. You have a chest x-ray which shows left-sided consolidation, ECGs, normal sinus rhythm, bloods, FPC, U's and E's are normal, CRP is 100. You have discussed with the senior and started the patient on coamoxiclav, stat furosemide, and given face mask oxygen. How would you make a referral to the medical registrar? Does anyone want to try? You'd even put some suggestions in the chat, or I can go straight into the approach. Good, so Natalie said SBAR. So that's basically what we're going to do. So SBAR is a tool, it's not a rule, it's something that could really help you. So you start with the situation. So mention your personal details. So we'll go through the scenario in more detail on the next slide. In terms of background, just a bit of background about the patient, what their baseline is, how they've changed. In terms of assessment, mention what you think the problem is, what you've done so far, and finally, recommendation. You need to be specific in what you want the doctor you're referring to do, and what further management they would suggest. So an example would be, so before you're referring, so this is basically for real life and for exam purposes, make sure you know your list of differentials, because often you will get asked, what do you think this is? So based on that little scenario, you could say that you think this patient has acute decompensation of chronic heart failure secondary to a lower respiratory tract infection or pneumonia. So you could start by saying, my name is Dr. X. I am an SHO, so senior house officer calling from the emergency department. Is it all right if I discuss the patient with you? And you can say why you're calling. So I'm calling about Mrs. X. As I'm concerned, she has acute decompensated heart failure secondary to pneumonia, and I think she needs medical admission. So you're putting it out there why you're calling the medical registrar. So Mrs. X is a 50-year-old with a background of cardiac failure. She's presenting with signs and symptoms suggestive of decompensation. I think that's a bit repetitive. You could probably not say the first line I mentioned and just say it all there. And then they're probably going to ask you, how have you come to this assessment? So you can say on history, she has worsening dyspnea, PND, productive cough, blah, 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 blah. And then clinically, she has mentioned the vital signs and any salient clinical findings to support your diagnosis. So don't talk about her bowel sounds are present. No, they don't. They want a succinct history and clinical findings pertinent to your diagnosis. And then it's important to say, like, in terms of investigations, what you've done, because most likely they're going to suggest what you need to still do. And then also what those investigations have shown. And then also just say, so far we've given her this, this, and this. Is there anything else you would like to know, or is there anything else we should do for her before you come down and see her? Yeah, so I think this is my approach, basically. Okay, so moving on to resources. We're almost at the end now. Sorry, it's gone a bit over time. So you can attend courses if you have the time and money, but remember that there are many people who have passed on their first attempt, like myself, without any courses. You can look up online YouTube tutorials. There are a lot of OSCE-based tutorials, and we will also be running future OSCE-based scenarios. They might not be live, but they will be on our YouTube channel. I think it's also important to find a virtual study partner or form a study group where you can practice And then there are also various PLAB forums on Facebook, which you can join. I was part of a few PLAB groups back about 2 years ago. I can't remember any of the names though, sorry. And then I just found this interesting article which was published in the career focus section of the BMJ. It's just 10 practical tips to make your PLAB 2 exam easier, which you guys can have a read of. And then just a summary of what we've gone through today. I think you should all visit the GMC site, watch all their videos, read all the good medical practice guidelines, try and invest in the Oxford Handbook of Clinical Medicine and Oxford Handbook of Clinical Specialties, because if you are planning to come here, they'll just be very useful for the exams and for just general practice. Know all your approaches to common medical emergencies very well, so like the back of your hand. Know doses of things, but also if you can't remember a dose, rather not say something that's incorrect. Rather say, I will look up this dose. That's the safest. They just want to know that you're a safe doctor with who abides by ethical practice, and yeah. And then read up on motivational interviewing and counseling, good medical practice, ethics, and breaking bad news. And practice, but don't write scripts or learn stock sayings. And be yourself, and above all, just be confident. I'm sure all of you will pass and it'll be fine. So the most important part, can we please ask that you all fill in this feedback form?